I'd like to move on now, please, to item 8 on the agenda, which is a series of reports from board committees. Board committees do a lot of the work of the board, and many of them have executive responsibility, but subject always to reporting back to the board itself. Victor, I wonder if we may kick off with you with CCG authorisation and assurance.
It's pretty clear as to what we've been up to and why. There are two things I'd draw your attention to. One is a minor amendment to the committee's terms of reference, really around increasing the scope to look at the development of CCGs, because we're moving into a slightly different phase now. CCGs are up and running, so it's about improvement en masse, continuous improvement, Kaizen and all that. And the second is the proposed delegated authority to initiate intervention where necessary. I mean, as CCGs move into their operational mode, it may well be necessary for the subcommittee to intervene, particularly where there are particular areas of immediate concern.
Thank you. Okay, thank you. I think we received that report. The second one is for me, which is the report of the Directly Commissioned Services Committee. We've had our inaugural meeting in August, in which we set about reviewing the terms of reference and trying to rationalise the terms of reference for the committee, and also the relationship between the committee and the Clinical Priorities Advisory Group, which is a group which will feed its intelligence back up to the main committee. We identified the principal areas in relation to the direct commissioning functions, which are set out in the brief report in front of you. And we received various updates in relation to primary care and specialised commissioning from the heads of commissioning. I'm going to ask Barbara to outline briefly one of the important decisions that we took and we reflected on quite carefully, which is around interim proposals for patient cohort and individual funding requests. Barbara.
Thanks, Chairman. As with all commissioned services, NHS England sets out those services which it routinely commissions and that we offer for patients and put contracts in place. However, there are times when, for reasons, we need to make an exception to some of the things that we perhaps wouldn't routinely commission, and we have to have a system in place for doing what are called individual funding requests. And if I can just give a couple of examples, that might be an instance whereby we may not routinely commission some sort of surgery that, for the most part, is cosmetic, but in an instance where the patient was having severe health problems because of that, then that would be a time of an exception. There may be certain treatments, drugs which are which are recommended for certain illnesses and not others, but there may be an exceptional occasion when, particularly at the end of life for patients, when it would be reasonable to use that drug even though it wasn't routinely used for that particular type of illness. That's very often common with the cancer drugs. So we have to have in place across NHS England a mechanism for identifying how we deal with those exceptions. We have a particular difficulty in that when you have you're likely to have a group of exceptions when it goes beyond a certain number, that you need to have a policy in place for how you will deal with those patients. And of course what we've done together, we're now one commissioning body when there were once 152. So we are in a position whereby, although we've got a comprehensive system of exception reporting of individual funding requests and the way we deal with those, there are quite a lot of instances now where we need very specific policies where we have cohorts of patients who would be, for whom the issue would be the same, and therefore they don't meet the exceptional category. So in essence, what the committee decided was that it was absolutely essential that in the interim patients weren't denied treatment if it was clinically necessary and urgent whilst we put those policies in place. It's a big task, and therefore the committee approved an interim policy whereby the area team directors would have the authority to make decisions on that basis until we could get to a place where we were confident that we had all the cohort policies in place. But notwithstanding that, we would then still need to go on with the individual funding requests.
I hope members of the board are happy to approve that. I mean, our view was we should simply get on and authorise it and argue about the money afterwards. So if you're content with that, we'll take that as approval. Thank you. That's all I have on directly commissioned services. Let me then move on to finance and investment. Moira.
Thanks, Malcolm. Paul may have something to add, but I don't have anything to add to the paper, which is a useful summary. Just to say, though, the challenge of monitoring spend during the year when there are so many wholly new organisations spending the money, as it were, is real. But also, so that's the new, but the old is also that we are picking up as a committee lots of things that have been in the system for a very long time, and in a sense, there are sometimes very limited choice for the committee to kind of resolve when it's got so far. But otherwise, commend the paper to the board.
Thank you, Moira. Paul, anything you'd like to add to that?
No, I think it's all in the paper.
Okay. May we then move on to the final of the report, which is procurement controls. Paul, back to you.
So this is the new improved version of the Procurement Controls Committee report, which now has values attached to it following the request at the last meeting. You can see the numbers on the following page. I have to say this is a committee which has got an enormous workload simply to keep the business flowing, because given the nature of the procurement controls that we work under, and I think the statistics on the page behind, the 79 that we have done in the period since the last report, give some measure of the challenge that we face in that. We continue to work with the Department of Health on the right level of procurement controls, and in particular in pursuit of the earned autonomy which comes from having the sort of system that we've put in place to manage procurement, which will prevent the risk, if you like, of double controls and therefore delays and bureaucracy in the system. We're not quite there yet, but we continue to work on that, and I anticipate progress will be made on that in the next few weeks. But beyond that, just for your information as to what we've been up to.
Thank you very much. May we take that report? Okay. Thanks. May we please now move on to item 9, which is the performance report. It's a very comprehensive document, and I'm assuming that it's been widely read by board members. I'm going to ask Tim to start off, but also other members of the executive team have had responsibility for different parts, including Bill, Barbara and Paul. But Tim, would you please kick off?
So yes, so this is the second iteration of the board report. We've tried to take account of comments made in the previous meeting, just to go back to the actions that I didn't talk to when we covered the minutes. But for example, giving greater ability to look at regional and regional variation, institutional variation at local organisational level in the data where it's possible. But a number of things still remain beyond our grasp, I'm afraid, and that's a system-wide issue to do with data and its frequency, which we're working on. But in broad terms, we are still unable on a sort of month-by-month basis in any meaningful way to, for example, track clinical outcomes at a level we want to. So that's except in very rare instances. So you'll still see that the section of, as it were, historic data is larger than the data we're able to manage in relation to sort of monitoring the scorecard that we've set ourselves in the business plan. That's sort of the bad news, although it's been an incredibly helpful stimulus to really putting pressure on getting better data out. The good news is that, having said all that, we have actually produced a whole bunch of new data, which I think it does really help us start to frame the way in which we're considering our our performance. First of those, obviously, the Friends and Family test. As I mentioned before, response rates across the service by June got up to over 15%, which was, I think, an exceptional achievement, though, of course, as I've also said, that's variable by provider institution. And broadly put, in inpatient care, the Friends and Family test was scoring the NHS at around 70 across England, and on A&E performance that was lower at around 50. So these are useful baselines. I mean, I think we shouldn't worry too much about month on month, but I think sort of as we start to accumulate more volume and response rates go up, this will become a very important, useful measure for us longitudinally as well as to give us comparison with other industries, other healthcare systems that use this as a measure, of which there are a lot. We also are able to report on cancer waiting times. We have included the results of the NHS England Staff Barometer for the first time, and we now have a full suite of financial data. So, I mean, I can take any further questions we have on the Friends and Family Test, but I feel we've probably covered that in previous comments quite fully. So perhaps I could just hand over to Barbara then to cover urgent care, and then after Barbara, Bill to speak to some of the business plan highlights that are in the summary report, and then perhaps on to Joe just to cover off on organisational health, and then finally to hand to Paul just to cover off on the financial data that's now in the report.
Okay, thank you, Tim. If I can take everyone to section C, because we want to look at some of the key areas of NHS performance that we've included, as well as the list on here. I would just like to talk for a few minutes about improving the access to psychological therapies, which is another major initiative in NHS England to which we're absolutely committed. Really, to take any questions on the slides, what we've tried to do here following the last board meeting, firstly you'll see that we've put more information in about the numbers of patients who are routinely seen in A&E departments or for elective care, because we felt that was important to the understanding of the kind of magnitude of the task that the NHS has. And we've tried in a number of the areas to give more indication of the spread rather than just one national figure. So, for example, on A&E performance, you can see that we've shown that the vast majority of organisations do meet the 95% standard, and a very, very small number are a long way adrift from it, with a middle-sized number actually coming quite close. And again, on the 18-week activity and the Ambulance Trust activity, we've tried to break this down to show the range that we get. And again, if I can move you on to the 18-week, which is page 7, you will see that there is quite a significant variation by trust as to how well they meet the standards of seeing patients. If you remember, the standards is about making sure the patient receives treatment within 18 weeks of being referred by their GP, and you can see that many trusts do this very well, but actually we've got a tail that really aren't delivering that standard of care for patients. One other thing I would highlight is the 111, which is on page 5. I think you will see just what a dramatic improvement there has been in 111 performance, particularly if you recognise that we've moved from 20% coverage of the country to 90% coverage of the country. The graph on the left actually shows that actually people are really meeting the quality indicators for this service absolutely consistently, and calls are being answered very quickly. We've got a really great satisfaction rate, 92% of patients satisfied with the service we're getting from 111. And then one of the most important ones is that we are, apart from a small number of calls, even if they have to be passed on to a clinician, the vast majority are being passed on to the clinician immediately. Patients aren't waiting to be rung back, except in a small number of cases. It's still not good enough, and we will, continue to try and improve this so that all patients are dealt with immediately. And I would like to reassure the board, as everyone's aware, that NHS Direct indicated that it felt it could no longer provide this service. We are having very, very constructive discussions with alternative providers, dominantly our ambulance trusts, but often working in partnership with out-of-hours providers who are the CCGs who commission this service. I know are close to being in a position to sign new contracts with the ambulance trusts for them to be able to, and the other cohort of providers, for them to be able to take over the service. But again, we're managing that very carefully carefully and absolutely in line with the Garland report. So every aspect of this transfer and the way it is dealt with, we will take the lessons from the Garland report and make sure that we've got full checkpoints for any transfer to a new service. We've got contingency from other places to cover the transfer. We'll put phasing in place to make sure that service stays stable. If I can just finish with IAPS before I see if anybody's got any questions. This is a really important initiative and very important in us in terms of it's improved. Sorry, it isn't in the papers, I'm afraid. I just wanted to give a verbal update on where we were with improving these therapies. It's really important for us in terms of ensuring that we have parity of esteem between physical and mental health. It's a service which CCG's commission. There has recently been a change in the way we report and collect on the data, which does look as if we have had a worsening of our performance, our trajectory, to ensure that the right number of patients are seen and treated over the next 18 months. We're hoping that the next letter of information, which comes out in October, will show that we're back on track to deliver the government's target on this. We've certainly got a huge range of initiatives in place in order to support CCGs to deliver this service, including strong clinical leadership, champions at CCG level, a lot of central initiatives from Martin McShane and his team in Bruce's directorate, and just to ensure that we get back on track and we make sure that patients do have good access to these services. Bruce, I don't know whether you want to add anything on IAPT.
Just a few words, if you don't mind.
Please.
The case for improving access to psychological therapies is based on really good economic and clinical grounds. And we have, I think, some quite tough implementation targets. By the end of 2015, we're meant to have access of 15% and a recovery rate for people who receive the services of 50%. We're on schedule for 12.4% access by the end of 2014, and we've got quite a comprehensive plan to accelerate progress. The point I think I'd like to make is with endeavours of this nature that the progress is seldom linear. It tends to accelerate as momentum is gained, and that's not least of all because training of therapists is taking time. And secondly, because one has to roll out, if you like, the acknowledgement of the economic and clinical case at a time when many CCGs and others are having to deal with some very difficult and conflicting clinical priorities. So our anticipation is one of optimism in terms of meeting the targets, and we're engaging. We have a comprehensive plan for engaging with CCGs. We're using the strategic clinical networks. We have a national clinical director who's focusing very heavily on this. We've engaged NHS Improving Quality and the Department of Health, who I've spoken to today, are engaging with Health Education England to help us on the difficult issue of recruiting people to deliver the services and training.
Can I just add something? I think I'm sure you didn't mean to do it in that way, Barbara, but as well as when you started this, you said it was a government target. And I think that's a very interesting way of putting it, because in a sense, this is the issue we've been dealing with over the last period, where quite a lot of people have seen this as a government target, in the sense of a politically driven target. And one of the big, I think, differences that we can do, and I think Bruce kind of really pointed that out really well, is that the way to get this change is to get the engagement and get the clinical leadership and get people locally to understand the nature and scale of the challenge, but also the evidence behind it to make it happen. And that's what we've been focusing our attention on over the last few months. How can we create that understanding and clinical patient leadership at a local level to make it happen? And that takes time and effort. It's not a question of setting out a trajectory and issuing instructions. That is not the way you get the kind of clinical change that you need here to make it happen. And I think all credit to Bruce and Martin and his team that they've tried to take a very different approach, much more consistent with the way in which we operate as an organisation to make this really important thing go forward. And I share with Bruce. I think we should be confident that we can make this happen.
Thank you.